Okay, I think we can get started. Welcome, everybody. My name is Dana Sanneman, and I'm the Vice President for Public Affairs and Development at Mount Sinai, South Nassau. I'd like to thank our panel for joining us today to discuss colorectal cancer and how to kick colorectal cancer's butt. Today, we'll be talking a little bit about how the hospital is using the latest advanced technologies, such as the Da Vinci robotic surgical system and others for minimally invasive and cutting-edge colorectal surgical procedures. I'd like to introduce our panel and thank them for taking the time to join us today. First is Dr. Dean Pappas, Chief of Colon and Rectal Surgery at Mount Sinai, South Nassau. Dr. Frank Gress, Chief of Interventional Endoscopy at Mount Sinai, South Nassau. Dr. Frank Caliendo, Director of Colon and Rectal Surgery at Mount Sinai, South Nassau, and Dr. Juan Baez. Thank you, everybody, for joining us today. We are going to show a short video that shows a little bit about the robotic procedures we're using. It is a little bit graphic, I'll warn you, but I think that you'll really find it interesting. So we'll show the video first, and then we're going to open it up to our audience for question and answer. We just ask that everyone stay on mute and pose any questions you have. It can be during the video, after the video, in the chat. And if you're unfamiliar with Zoom, if you're looking at your screen, hover over it with your mouse, you'll see the chat bubble right in the middle of the navigation bar at the bottom. And you can put all questions right in that chat. So we'll start our video. And again, if you have any questions, you can pose them in the chat at any time. Thank you.
Hi, I'm Dr. Frank Caliendo, and I'm the Director of Colon and Rectal Surgery here at Mount Sinai, South Nassau Hospital. Generally speaking, all the conditions that affect the colon and rectum can be treated robotically. There are opportunities to proceed with diverticulitis surgery, surgery for Crohn's disease, ulcerative colitis, colon cancer, rectal cancer. Most of the conditions that we see and recommend surgery for can be done with the use of the robot. There are times when colon cancer is so advanced that surgery is not recommended. However, if surgery is indicated, then it can definitely be done with the robot, and there are definite advantages to doing colon cancer surgery with the robot. The biggest advantage of robotic surgery for colon cancer is the minimally invasive technique. Open surgery, there are large incisions, which leads to prolonged ileus, which is the small intestine and the colon basically go to sleep and don't recover for many days. When I trained 20 years ago, patients had open surgery. They had NG tubes, which is a tube into the stomach, for many days. And the length of stay was easily 7 to 10 days just to wait for the bowel to recover. With the advent of laparoscopic surgery, that length of stay was reduced. Now with robotic surgery and with an advanced recovery protocol that we have in place, we're sending over 95% of our patients home in 2 days. When I used to counsel patients and tell them they would be in the hospital for about 5 days, it's now easily telling them they're going to be in the hospital for 2 days. And in some select patients, they could even go home the following day. The advantage is because of the minimally invasive technique. We have very small incisions, like 1.5 inches, 1 inch sometimes, and the robot ports are about 8 millimeters a piece. So all in all, the patients have much smaller incisions. They don't take any narcotic pain medicine, and there's no exposure of the intestines to the air. And all of this together with the protocol we've had in place, the bowels recover much faster, and we're able to send patients home safely in about 2 days. We're able to visualize and do more precise surgery. The robot arms have wrists. They have 7 degrees of motion, where traditional laparoscopic instruments are very rigid. They're just straight instruments. So with the use of the robotic instruments, we can go around corners. We can essentially almost have our hands in the abdomen because the robot instruments mimic our hands as we use them at the console. So if I move my hand in a way that's sweeping with my wrist, the instrument also sweeps. So there is more precise visualization, more precise surgery, which leads to less bleeding and less infection also, because in removing intestine or bowel, there used to be a very high incidence of wound infections. Now with very, very small incisions, and we use what's called a wound protector to extract the bowel, the rate of infection is dramatically lowered. So one tremendous advantage of the robot with colorectal surgery is facilitating pelvic surgery. So the pelvis is a very tight and narrow space within the body, and the robot, with its ability to have wrists and arms, we can do much more precise pelvic surgery than was ever before capable. We are able to go lower. We harvest more lymph nodes. We get greater negative margins, which is all very important with rectal cancer surgery. So if there was one advantage of the robot, it is absolutely pelvic surgery without question.
Let me start by saying this virus is very serious. You do not want to get it. The virus can affect individuals in very different ways. I myself was fairly ill. I was out of commission for approximately 3 weeks, had to be treated at this hospital, and I got excellent care, I'll say, but it's extremely serious, and I'm relatively young and have no comorbidities, and I was quite ill. Please, all I can emphasize is get your vaccine as soon as you can, and follow the CDC guidelines, social distance, wear your mask. This isn't over yet, and it is very important that we continue to fight this virus very diligently until we achieve the herd immunity and we can all let our guard down a bit, but we're not at that point yet. I've been living in the COVID world since the day it got here. We've been performing surgeries on COVID patients. I've been watching this disease affect people, and for the most part, young healthy people do quite well, but it's certainly not the rule. Young healthy people can get very ill. We've seen young healthy people pass away. Just a message out there, everyone. This is not over. With regard to screening and subsequent treatment, it is imperative that you maintain your screening protocols, whatever that may be. Unfortunately, we've seen a dramatic decline in, for example, the number of colonoscopies that are being performed in the area, and it's understandable, but it is at a detriment. We are certainly seeing now patients who are coming in with advanced disease, who, if they had the procedure a year ago, possibly would have been in a better situation. I have, for example, a 62-year-old gentleman that I saw at the very beginning of the pandemic with a cancer. He did not want to follow through with surgery that time. I understand, but he decided to wait, and he now presents with stage 4 disease, and he is now no longer curable. So he went from a condition that was curable to now, unfortunately, there's not much we can do for him. This is very serious. It's important to get your screenings, and if anything is found, you must follow through. We are taking every precaution here at Mount Sinai, South Nassau. You do not have to be afraid to come to the hospital. Every possible protective measure is being done. You're much more likely to catch the virus in a restaurant than you are here at this hospital. Please, everyone, it's imperative that you maintain your screening protocols. Go see your physician if you don't feel well. Do not avoid the medical system at this time, even though it is understandable, but that fear is a bit misplaced, and it's potentially could cost you your life. So here at Mount Sinai, South Nassau, of course, masks are worn at all times in the hospital. The cleaning that is done in the facility is second to none. All the rooms are decontaminated after patients are in them. Proper ventilation systems have been put into place. We're not seeing, for example, hospital employees get infected at a higher rate than the average population. In fact, hospital employees are getting infected at lower rates compared to the population, which is unbelievable to think we're dealing with COVID, and yet we're seeing infection rates lower than if you're, out in the community. So it's safer to be here than outside. As colorectal surgeons, we do quite a bit of colonoscopy, and we deal with removing polyps. A polyp grows relatively slowly. However, this pandemic has been going on for a year, and polyps can certainly grow to the point where a polyp that could have been treated relatively easily with a minor procedure now is going to require a more complicated procedure to remove that polyp. It could mean the difference between a 10-minute colonoscopy and using a simple device to remove the polyp. And here we are a year later. Now I either have to take you to the OR or I have to do a much more advanced endoscopic procedure that has the potential for more blood loss, for even a perforation requiring surgery. So certainly even conditions that are benign can progress if you're not followed and screened. And your treatment is going to be much more difficult and potentially even, life-threatening. So for example, people that they have polyps and they were told you need a colonoscopy in 3 years. A lot of patients saying, I'm going to wait another year because of the pandemic. That's a big mistake. In that 4th year, when you have now your colonoscopy, we may find a polyp that requires advanced techniques to remove, where if we found that a year earlier, it literally could have been a 10, 15-minute procedure.
So we are getting some questions in the chat. Please continue to put them there and we'll monitor them. I'd like to just start by asking Dr. Gress. I know Dr. Pappas touched on this in the video, but it still remains an important question. Many people in our community have not seen a doctor since before the pandemic and are still nervous about coming to the hospital. What can you tell people about the measures the hospital is taking to keep people safe?
So as Dr. Pappas said, it's very safe here in the hospital. I can't stress that enough. Our endoscopy unit is state of the art. And keep in mind that everyone that works in our endoscopy unit has been vaccinated. Every patient that comes in for a procedure has a COVID test prior to their arrival. So it's probably one of the safest places to be to have a colonoscopy. So I must reassure everyone that if that's a concern, I think having the colonoscopy is more important for you because you really want to identify colon cancer early. If you don't identify it early, as Dr. Pappas said and Dr. Caliendo, you'll be seeing them for an operation. Having a colonoscopy is very routine nowadays. It's safe in our endoscopy suite. You can go in, have the procedure. If we see a polyp, we take it out and we eliminate the risk there for you for colon cancer. So again, I can't stress enough not to be worried about this. It is a very safe environment.
Thank you. And Dr. Pappas, Jeannie, who's a patient of yours in our chat, just really reiterated everything we've been talking about. She's a 59-year-old woman. She got her colonoscopy and you found a cancerous tumor. She was in the hospital on March 16th, home on the 18th, and had her surgery with a robotic device. So Dr. Baez, maybe you can just talk to us about what are the current screening guidelines? Who should be screened? Who should have a colonoscopy? What are the ages now? What are the recommendations?
So traditionally speaking, we've thought about 50, the age for initial screening colonoscopies in what we call average risk individuals. So that means, individuals with no family histories of colon cancer. More recently, the American Cancer Society has come out and formally recommended lowering the age of initial screening to 45 years in patients that are considered average risk. And certainly in patients that are high risk, those patients with family members with colon cancer, most significantly, if there's a first degree relative, they should be getting screenings earlier. So if the age of diagnosis is known, it should be 10 years younger than the age at which their family member was diagnosed with colon cancer.
Thank you. That's helpful. Dr. Pappas, Fred asked, what are some of the symptoms of colon cancer? Maybe you're not due for your colonoscopy, but you're noticing certain things. What should you look out for?
Sure. Symptoms of colorectal cancer, first of all, the scariest symptom is that there are usually no symptoms, and that's why screening is so important. The vast majority of patients, over 80% of patients with colorectal cancer have no symptoms at all. So we hear people say all the time, I have no family history, I have no symptoms, and I go to the bathroom every day, so I must be fine. And that is simply not the case. Everybody needs to get checked. But If you start developing symptoms such as weight loss, abdominal discomfort, a change in your bowel routine, you're going to the bathroom less frequently, more frequently, change in the color or caliber of the stool, difficulty with evacuation, all of those types of symptoms need to be addressed. So in addition, we also like to say there's no such thing as normal rectal bleeding. Any blood that anyone sees is not normal. Patients come in and they go through this whole process. Oh, it's bright red and that means this, or it's dark and that means that, or it's on the paper. If you play that game, it's dangerous. Any bleeding needs to be addressed. I don't care if you're 15 years old or you're 95 years old. So again, the take-home message is everyone needs to get checked at 45, but any symptoms, regardless of age, if you're having symptoms that I just described, you should be checked.
And another person in the chat was asking if they do have a family history, what age should they be screened? And then how often after that should they do follow-up screenings?
So the common recommendation is 10 years before the first degree family member was diagnosed. So for example, you have your sister had colon cancer at 40. You need to, if you're a first degree relative, so first degree means sibling, parent, or child, they need to be scoped at 30, so 10 years before. Then based on the results of that scope, we'll determine what the next steps are. Typically, colonoscopies are every 10 years, but if you have any polyps or there are any other factors that could be done sooner. There are some genetic colon cancers. There's a condition called Lynch syndrome that we see in about 5% of patients with colorectal cancer. And in those patients, they need to be screened frequently, every year, actually, because their risks are quite high. So, but to answer your question, it's 10 years before the family member was diagnosed.
Now, Dr. Caliendo, one of the things that may deter someone from getting a colonoscopy is the colonoscopy prep. So has the prep gotten any easier?
So yes, that I hear that all the time, and it was quite brutal up until a few years ago. It's constantly changing. There's no perfect prep, but instead of having to drink an entire gallon of vial fluid, there are recent new preps on the market. One of which, for example, I just had a colonoscopy in February, and I took a prep where it's 2 7-ounce bottles, and each bottle tasted like a raspberry NutraSweet syrup. And as long as you mix it with water, it went down without a problem. And what we're doing now too is, depending upon the time of your colonoscopy, we actually do what's called a split dose. So you don't have to drink the entire prep all at once. We actually split it by about 6 hours. Sometimes patients are taking that the day before the colonoscopy. And some patients, if the colonoscopy happens to be later in the morning or early afternoon, they'll actually take one part of the prep in the evening before and one part of the prep in the morning of. So yes, the prep is something that people are concerned about, but there are multiple new formulations that are pretty well tolerated. There will certainly be a prep that most patients now, after they take it, they say it's not bad. It's not bad. Certainly not the way it was, 5 years or so ago.
And while we have you on the topic, there's a couple of questions in the chat. What about Cologuard or the Abbott stool test? Is that, should I do my own colonoscopy at home?
So Cologuard is a good test, but what it does, it's trying to obtain DNA from a potential cancer. And it is not as good as a colonoscopy. There are false positives, which I've personally scoped patients who've come in, and the reason for a colonoscopy was they had a positive Cologuard and we don't find a colon cancer. And there are false negatives. So they get a negative test, they think everything's okay, but indeed there is a colon cancer as well. And I would just say that screening for colon cancer is just that. The age the age that it's initiated at and the interval is trying to find colon cancer. But all of us, I think, would agree that we're kind of pleased when we do a colonoscopy and we find a large polyp or a polyp that we can remove that's benign. So although we are trying to diagnose cancer earlier, but we do find many polyps that would otherwise turn into cancer if they weren't removed. So in short, if you're young, healthy, and have really no significant comorbidities, you should absolutely have a colonoscopy and not Cologuard. We would reserve Cologuard to patients who have risk factors to colonoscopy, or the aged who may be averse to having a colonoscopy later in life. But absolutely, colonoscopy is much more specific.
Thank you. And Dr. Gress, someone who's in their 50s or has other factors that they need to have a colonoscopy, what is the best way for them to go about doing it? Should they see their primary care doctor first?
Well, that's variable. Some patients will be referred by their primary care physician. Primary care physicians obviously take the interest of their patients at heart. They really make sure that patients get the screenings that they need. So a lot of times patients will be referred from their primary care. But also we see a lot of patients that will come into our office specifically for colon cancer screening. They know that gastroenterologists, offer that procedure and do it. So, I would say about half of the patients that come to me for screenings will be actually referred through word of mouth, through their friends who've had colonoscopies. They go, a lot of them will come to us, based on word of mouth, or the other half are referred by primary care interns.
And is there anyone who should not have a colonoscopy, like pregnant women, for example? Are there any restrictions?
Well, I mean, we try to reserve this for when the patient is the healthiest. Obviously, everybody should get an index colonoscopy. That's index meaning the first colonoscopy at the age of 45. Of course, if someone's pregnant, I would always defer that as long as there's no symptoms until after the pregnancy. But the most important thing is to have that index colonoscopy when you are supposed to have it. And that way we can decide, what's your interval for surveillance in colonoscopy. So, the difference that you have to understand is that a screening is only as good as the time you have it done. You have it done at, if you're 45 and you have it done at 45, you get identified. If you have polyps, then we're going to do what we call surveillance colonoscopy at an interval based on the number of polyps and what we find. If you have no polyps, then the recommendation is 10 years. If you have symptoms, it's obviously a little bit different, but it's very important to have that index colonoscopy. I would say everybody should get that. Obviously there are patients who have, as they get older, have problems, particularly with other health issues like heart issues and things like that we have to work with their physicians on. But most patients are healthy enough to have that.
Okay. And Dr. Baez, where are most colonoscopies done? I know at Mount Sinai South Nassau, we do them in the hospital. There's a question on the chat from somebody who had a colonoscopy done at a doctor's office. Where are the different locations?
Yeah, so there's different venues for having a colonoscopy. There are ambulatory surgical centers, which are centers where, as the name describes, you present for your procedure, you undergo procedures. They're usually facilities where they're exclusively performing these procedures all day long, and have dedicated staff that's qualified to manage patients undergoing these procedures. Some doctors' offices can also offer colonoscopies, and as well as a hospital setting.
Okay, thank you. Dr. Pappas, I want to go back to you. In the video, we actually showed our Da Vinci robot performing the procedure. Tell us a little bit more about the robot. What are the minimally invasive technologies that the robot uses?
Sure. So at Mount Sinai South Nassau, we now have two Da Vinci robotic systems. state of the art. It's called the XI system. So it's the best you can get. It's an amazing amazing machine. It allows us to do things that we simply couldn't do before, minimally invasively. You know, the progression, as Dr. Caliendo said in the video, we went from open surgery making large incisions to laparoscopy making small incisions, and that was a huge leap. But the laparoscopic instruments, they're almost like chopsticks, is a good way to think of them. And the robotic instruments have wrists, and you can imagine now the dexterity that we have using this tool allows us to do things that we simply couldn't do before. We can sew in places that we couldn't sew before. We can see things better. So it's a huge advance in surgery. And again, we are very proficient in this. We do all of our surgery now robotically. You know, 80% of the colon surgery in this country is still done open. And so, you know, finding a qualified surgeon that can do these procedures is critical. So, you know, you can get home in a couple of days instead of, you know, staying in the hospital for 7-10 days because you had a big incision. So the leap from open to laparoscopy was a huge one. And now from laparoscopy to robotics is even greater. So, you know, all I can say is we're very lucky that Mount Sinai South Nassau has, you know, the support that this institution is giving to us as surgeons. You know, just these machines are very cumbersome, and they require a lot of support from the staff. And we have a phenomenal team. We have our own OR. We have our own robotic team. Our patients go to their own floor, private rooms. So all I can tell you is we're very lucky that we're working with Mount Sinai South Nassau, and we have the capability to do these types of procedures with the, you know, state-of-the-art equipment.
So I'll ask you one question in closing and your last minute advice, and then I'll go down the panel. But I'm traveling for the summer, and I'd rather wait until after the summer to have my screening colonoscopy, even though I haven't had one since before COVID. What's your advice?
So again, you know, we recommend colonoscopies at 45. The concept of waiting is dangerous. It really is. Now, look, a month or two, we don't want to be dramatic here. If you know, you're going on a trip a few months, I don't think is a big deal at all. But you know, we see patients showing up, they're 65 years old, they've never had it, you know, 80 years old, they've never had, you're really rolling the dice if you're not getting your screening colonoscopy. So it's important that, you know, you make a concerted effort, you put it on your list. This is what I'm going to get it done, and you hunker down and you do it. And if, you know, most patients, you do it every decade. It's not a big ask. There are 150,000 cases of colon cancer in this country every year, 150,000, and 50,000 of those people will die. And it is completely preventable if you get a colonoscopy. It's a sin that there's even one case of colorectal cancer. So we can't state it enough. Please get screened.
And colonoscopies are not dangerous, correct?
The complication rate is in the, you know, hundreds of a percent. You're talking like a 0.0, you know, 1% chance of complications. It's not, you know, without risk, and you do have to take it seriously, but in competent hands, it's, you know, I tell my patients driving to the center, driving to the hospital to get your procedure done is more dangerous than the procedure. So it's not without risk, but the risk is exceedingly low.
Thank you. Dr. Caliendo, any closing remarks for I think we've got everyone's questions on the chat covered. You know, there are a couple of questions that we can have one of the doctors contact you directly about, or have a member of their staff contact you about. But I think we got everyone else's questions. So Dr. Caliendo, any closing remarks?
I would just echo what the rest of my colleagues have said. Waiting, you know, to go on a trip is one thing, but waiting years to get screened is really not a good idea. And my message would be that I have operated on a 26, actually, I take that back, a 19-year-old young man with colon cancer. That was my youngest was 28, and now it's 19. So that's the youngest I've seen. And that just means it can happen to anybody at any time. And he had no risk factors. He had no family history. just kind of ignored symptoms a bit, but at 19, listen to your body, my advice would be. And if you do fall into the general population where you don't have a family history and you're not having symptoms, then at 45, you really should get a colonoscopy performed. It is really one of the easiest things you will ever have to go through. And it's one of the best, absolute best tests in medicine. There's a camera inside of the organ where something can grow. Colon cancer doesn't grow on the outside. X-rays, CAT scans, they're all shades of gray. They need to be interpreted. A colonoscopy, you're literally in the organ visualizing the surface. And so again, just to echo what my colleagues have said as well, just get your screening colonoscopy when it's time.
Great. Dr. Baez, any closing remarks?
Yes, I would like to add one thing about colonoscopies as a preventative measure for cancer. So really, it's the only modality out there where you're actually preventing cancer. Because when we're doing these colonoscopies, it's really a scavenger hunt for these polyps. And these polyps are what's going to become the cancer. They're slow growing, but over time, eventually, every single adenoma will become a cancer. So we have the ability to actually prevent cancer. And as Dr. Pappas alluded to, this completely avoidable cancer. And so it's really imperative that we not lose sight of it, not put things off and go for colonoscopy screenings.
Thank you. Good point. Thank you for bringing that up. Dr. Gress, any closing remarks?
So I would tell everyone not to hold off in getting your colonoscopy. People always find excuses not to do things. So it's very, very important that you get the colonoscopy when you need it. A few months here and there is not going to be the issue, but as you've heard from my other colleagues on the Zoom, don't keep putting it off, because the longer you put it off, the more troubles you may have. This is a completely preventable cancer. We can cure it just by taking the polyp out of your colon if we find one. And if you don't have anything in your colon, it's something that you can be well assured that for the most part, you have very little chance of getting colon cancer, as long as you abide by the screening protocols and guidelines. So I would just implore upon you to have your colonoscopy when you're due for it by your age group. And if you have any symptoms that may be concerning, go to your doctor. You can come to one of us, here. But you really need to, investigate any symptoms that are what we call the worrisome signs of colon cancer.
Thank you. I know there are a couple of questions in the chat that maybe require some direct communication with the doctor. So I will have someone from their staff reach out to you directly. We have your contact information. Again, if there are no further questions, I'd like to thank everybody for joining us today. We will be sharing this presentation again on our website and social media. But thank you everyone for joining. This was an important topic and we appreciate your feedback.
Thanks, everybody.
Thank you.
Thank you, everybody.
Thank you.